Hello, hello. How are y'all doing? All right. Hello. Good deal. Give everybody a couple minutes to log in, and then we'll get this party started. If you haven't emailed me, if you're an athlete, please do so. I'm starting to work on y'all's senior clinical schedule. And right now I have Mondays and Fridays for clinical. I'm trying to put the majority of the athletes on Mondays, but I only have 12 spots. So it's going to be to the first come, first serve on who lets me know. Right. This test is typically, I don't like to use the word easier, but it's more straightforward than like endocrine, fluid electrolytes, acid base imbalance. I feel like when I see dips in grades with endocrine and fluid electrolyte, because it used to be fluid electrolyte and endocrine went together, which was really heavy, we would see a giant spike up in grades with skin and musculoskeletal. So if you're nervous, please don't be, because I think you'll see a big improvement on this. All right. Welcome, welcome. And then if y'all don't mind turning on your cameras, if you can, so that like it just kind of makes us all feel a little bit more part of the team. You don't have to, but I'd be grateful because then I feel like I'm out here like talking to myself. Okay. All right. So let's get started. What I'm going to do is, good deal. All right. What I'm going to do is I'm going to share my screen and we are going to start going through your test blueprint. Have y'all seen this? Have y'all started working on this? Okay, some of you've seen it, some of you not started working on it. What else do you need to cover before the test? What else is coming up? Because you've got class on Thursday.
We're going over musculoskeletal right now.
Okay, going over musculoskeletal.
She hasn't covered skin, burns, and she did half of arthritis.
Half of arthritis. Okay, so let me start with this. All right, perfect. So let's then start with musculoskeletal. And then on Sunday night, I'll go over burns and skin. Burns is a lot of fun. I love burns. And then we can finish up with a big review on, I think it's Tuesday night or Wednesday night is our last session. Okay, so have you talked about fractures yet? Okay, good. So we can start there. Starting right off the top, what is an ORIF? What does that stand for? Anybody remember? No? Open reduction, internal fixation? Does that sound familiar? So you've got a break, right? And you've got an open fracture or a closed fracture. What does that mean? When you've got a closed fracture, what does that mean?
It didn't exit the skin. It's like everything's inside.
That's right. It's inside the skin. Open. It's open to the outside. You see the bone. It's pretty graphic, right? What do you think that patient's at risk for if you can see the bone? Infection. You got it. Infection, big time, right? Depending on the trauma or however this, I mean, if you've broken a bone and it's outside the skin, there's some major trauma right there. Especially if you're talking about like a lower leg bone, a femur, something like that, you're talking about risk for hemorrhage. And if you sever the femoral artery, you're not long for this world. So there's a lot of trauma that goes into breaks. But long story short, open fracture, you can see the bone. Closed, it's inside the skin still. So when we do an open reduction internal fixation, this just means we're going into the skin. It can be a closed fracture or an open fracture, depends on the severity of the break. They will go in and do the internal fixation, right? Pins, rods, plates, all that jazz, all that magic to put the bone back together again. And then reduction is a fancy word for putting it back together. A reduction means you're putting the bone back together. Why do we do ORIS? We do them because they make the patient heal faster. And it's just a quicker way to get Humpty Dumpty back together again. And we like to do it because, of course, it's faster. But again, you said it. What is the number one risk for an ORIF? You're going in, you're doing surgery.
Infection.
You got it, infection. So if you see a test question, doctor's going to go in preparing the patient for an ORIF. What is your priority prevention? It's infection, right? Because you're now going in and you're doing these major surgical interventions. So ORIF, internal reduction, open reduction, internal fixation. You're going in, you're fixing the bone break. Tell me about cath care. What are some things that you want to teach our patients? I guarantee there's going to be a teaching question about cath care.
Cover with the bag during the shower.
Yep, don't let it get wet. Nowadays they've got cash you can swim in, but let's remember, like, don't get it wet. How are we going to handle it? A wet cast before it hardens. Palms of your hands. Don't cause little indentions, because then you're going to cause pressure points on the leg. Okay. What if they're itching? Should they go ahead and get like a pen or a pencil and go down there and scratch? No, don't let them stick anything inside the cast. Okay. Especially kids. They love to stick things inside their casts. So get them some Benadryl or prescribe them something like that to help with the itching. Okay. So nothing in the cast. Hold it with the palms of your hands while it's still drying. Don't allow for pressure points, and educate not to stick anything in the cast. Okay. Compartment syndrome. What are the 6 P's of compartment syndrome? Anybody know?
Pain, pallor.
Paresthesia.
Paresthesia, pain, pallor. That's 3. I always have to write them out because then I start to repeat myself. Pain, pallor, paresthesia, which is a fancy word for tingling. Sure.
Pulselessness.
Pulselessness. 2, 3, 4, 5. We said pallor, pain, pressure, pulselessness. And last but not least, paralysis. Now they can't feel it. If you get to pulselessness and paralysis, you've missed the boat. This is a bad day for the patient. This is bad because you've lost circulation. So what happens is compartment syndrome is, right, you've got a break, right? And your body knows, like, I've got a boo-boo. I've got to kick off the, immune system response, inflammatory response to go down there, send the osteoclast and all this other jazz down there so that we can fix this break, right? And so body does its thing to go down there. And what's going to happen, right? Think about any time you've gotten a boo-boo. The area swells up, right? And so that's why a lot of times when we have somebody come into the ER with like a leg fracture, ankle fracture, et cetera, we're not that quick to throw a cast on them right there in the first, hours, because that extremity, I'm talking about extremities here, those are going to swell. And so if we throw a cast on there, a movable structure, meets a movable structure, we're going to build pressure in that cast, and we can have a risk of cutting off circulation, right? Because that leg, I'm thinking about a leg in my head, starts to swell. Cast is not going to allow for any swelling. And then bam, you cut off circulation. And that's what compartment syndrome is. It's when you cut off circulation. And so your body will say, ooh, I'm starting to have some pain. I think about like girls with hair ties. I always, throughout the day, I will have hair tie. And then I'll look down, I'm like, why is my hand numb? And I've cut off circulation to my hand. But the first thing I feel is that like tingling, right? That's a stupid example, but it's just, it's what I got at 8 a.m., guys. So you cut off circulation, the first thing you're gonna feel is pain. Then that tingling, pressure, okay, patient's gonna say, they're not gonna say, I think I'm getting some compartment syndrome. I'm getting some paresthesia going on. No, they're going to say, my pain is increasing. you just, and then you're gonna say, okay, well, you just broke your leg. Let's get you some more morphine. You give them some morphine. Hour later, they're like, nope, this morphine's not touching it. Something's not right. My pain's going up. So you've given pain medicine, you're watching the site, and their pain is still increasing. That's a call to the provider, because then, of course, then you're gonna like go and assess, and you're gonna feel for pulses. Maybe you still have them, but you're feeling the extremity and it's cool. So maybe we've got some pallor going on. They're complaining of tingling. So that's like, we may have compartment syndrome. So when you get your scratch paper for the test, I would write the 6 P's up at the top, because I guarantee you they're going to ask about compartment syndrome, because that's syndrome too in burns. It's different kind of flavor, but it's a still kind of same thing. What do you think our treatment is? We've got a lower leg cast. We figured out, we may have some compartment syndrome. What are we going to do to fix it?
Can't they like cut the leg open?
Yeah, they're gonna do a fasciotomy. They're gonna get that cast off, and then they're gonna go zoop, prepare them for the ER or OR. They're gonna cut the fascia open so they can release that pressure and then hopefully get back circulation. That's what we're gonna do for compartment syndrome. So you get a test question, patient diagnosed with compartment syndrome. What are you as a nurse gonna prepare for? And you're gonna prepare for a fasciotomy. You're going to start getting that patient ready for the OR. You're calling the OR, you're calling report, you're getting their chart together, finding out when the last time they had something to eat or drink was, et cetera, because they've just bought themselves a fasciotomy to, restore that circulation. So that's a medical emergency. And so again, kind of why we don't put casts on right away unless we absolutely have to. With burns, you'll see compartment syndrome because you haven't got to burns yet, but I love burns. When you have a patient and we're talking major burn, we're not talking about you burnt your hand on the stove and you're having a bad day. We're talking about house fires. We're talking about car accidents with car bursts and flames, and you're taking care of a patient with a large total body surface area burn. What is the definition of a large total body surface area burn? Something greater than 20%. And if it's a kiddo, the percentage drops down, right? So a major burn, anything to the eyes, hands, genitalia, and then large surfaces of the body. What happens in a burn is very quickly after the burn, the patient will go into compartment syndrome, okay? So you've had this major trauma. Your body will literally go, no, this stinks. And fluid from your vasculature will go out to your extremities. You'll get third spacing. You're going to swell up. These patients are at big risk for hypovolemic shock. So we are pounding them full of fluids in those first initial hours after a major burn. Where does all that fluid go, right? It goes to different areas. So like you will see swelling occur and they've been burned, right? So they may have eschar or eschar, or however you want to say it, along their like abdomen, chest, arms, et cetera, et cetera. And that eschar acts like a cast. So now you've got swelling and you've got this eschar, however you want to say it, that doesn't allow for that swelling to go anywhere, and you lose circulation. Especially you got to watch those circumferential burns all the way around the extremity or chest. And then you go in and do an escharotomy. And that's the big fancy different term. Instead of a fasciotomy, you're doing escharotomy. You're cutting open that burned skin so that you can release that pressure and hopefully regain circulation to the area. So a lot of cool burn stuff out there. And I've had 2 students go to the burn ICU at KU for capstones. So know that that's an option to go to the burn ICU for your capstone, okay? In the spring, next spring, so that'll be fun. Any questions about compartment syndrome? Okay, so memorize those 6 P's. I guarantee you're gonna see them again. What do we do to treat it? Prepare for an emergency fasciotomy, because we gotta restore that circulation. Okay, hip fractures. Hip fractures are a wah-wah, especially in our elderly population. And you can write that down, just write wah-wah. It really is a high risk for mortality when we get up there and our age is greater than 65, 70. And if they've got a comorbidity and you get a hip fracture, it's a bad day. And it's a bad day because the recovery from it takes so much out of the patient, right? And so hip fractures, know your, like, patient education stuff with that, right? Can't, and I don't have the PowerPoint right in front of me, but I believe there's a slide where it's like, don't flex the hip greater than 90 degrees, don't cross the ankles, can't drive for 6 weeks. So look over those hip fracture education points and you'll be good to go with hip fracture, because that's going to be where we're going to teach it. We got to teach the patient. It's going to be like, does the patient need more teaching? I'm going to drive in 2 weeks. Uh-oh, we need to give more education because you're not driving in 2 weeks. You're not driving for 6 weeks. Okay. Avascular necrosis, we've had a fracture and it is just not healing right. And we get an infection in there. And so necrosis, infection, death of tissue, right? The bone starts to die. And we can see that, we see that in, see it in cancer. We see it in hip fractures that aren't healing well. We see it in, example, I saw a newborn baby, vitamin K shot. The nurse hit the bone, hit the femur, and developed an osteomyelitis that then turned into an avascular necrosis. I mean, it's just one of those terrible situations where you've got a brand new baby and they're losing parts of their femur. So long story short, what's the treatment? We're going to do lots of antibiotics. How do we know we're developing an avascular necrosis? Well, pain. A person won't use that extremity if they're nonverbal, if it's a, baby, or if it's somebody who can't speak or whatever, but you notice you're limping, you're not using it appropriately. So the big goal on that is get them on antibiotics, try to fix it. If not, surgical intervention, cut out the part that's dead, and go from there. Okay. All right. Take a pause because I know I'm talking really fast. It's already been 20 minutes. Okay. I love breaks. Okay. Fractures, types of fractures. Which is the one, which fracture of these listed here that you see, do we maybe want to get more of the history about? Which one do we want to maybe suspect abuse? Spiral. Absolutely, spiral fractures. It takes a lot to break a baby's bones. And so then when you have a family come in and they do an x-ray and you notice it's a spiral fracture, that lets us know that the baby's been shaken or the child's been shaken, twist, grabbing them by the arm and twisting up. And so on these fractures, you need to look at the whole picture, right? Look at the story. This is where, and I've said this before, we are not detectives. We are not the police. So I don't expect any of you to interrogate a family, especially if we don't know if it's abuse or not. So to be accused of that would be terrible, right? But let them talk. This is the time where you're like, so what happened? The story or the mechanism of injury needs to match the child's developmental age, right? If they're not cruising, they shouldn't be bruising, okay? So you have a 2-month-old that comes in with a spiral fracture. Oh, they were crawling around and they fell. It's like, that seems odd. Again, you're not the police, so what are you gonna do with your face? You're gonna keep it poker face. Oh my gosh, that's terrible. That's terrible. And then next family member, what happened? Let them talk. Chances are the stories aren't gonna match up. This is where your documentation is crucial because you will be called to court on stuff like this, okay? So again, spiral fracture, we need to think abuse. If it doesn't match the developmental age, you need to look into it further. You're not the police. You're gonna document. You're gonna notify your charge nurse, who's gonna notify the police, who's gonna notify CPS, and go from there. Oh, we got some support with Caitlin. Woo! Gosh. Okay, good deal. What is another pediatric fracture that you see on here listed? What's another one? Commuted, green stick, spiral, compound, pathological, open, closed.
Be green stick?
Yeah, absolutely. That's where you got the kiddo running and then they fall and one side is bent and then the other side's got a little fracture on it. Kiddo bones, like I said, they're really hard to break. And so what you'll find is it'll bend, have kind of like a bend motion. So you see it a lot in I'm a terrible mom. I had my 10-year-old son at the time race our yellow lab down the street at Fort Leavenworth, and I was recording it, and I was like, ready, go. And they take off, but Bex, our dog, cut him off, so he totally fell, and I heard the fracture happen. And I was just like, oh, okay, I'm going to jail. But yeah, but it ended up being like a green stick fracture because they've got lovely little bendy bones. All right. What do you think a pathological fracture is?
Like maybe if there's not enough, if there's something wrong with the parathyroid or something like that, and so that makes you have like less calcium, making bones weaker.
I like that. I like also cancer. I like somebody who has something going on that causes their bones to get weak. So yeah. So what do we need? Especially elderly women, right? What are we at risk for? Osteoporosis. What do we need to educate our osteoporosis at risk patients? Don't fall. For the love of God, don't fall. You've got osteoporosis. If you fall, you're going to break something. And if it's a hip, it's going to be a bad day. You see how this all kind of relates? What is osteoporosis? Very sporous bones, lots of spores, pores, not spores, pores, very porous bone, weak. So we need to, we'll talk about that when we get to that, Jazz. But yeah, pathological, you've got sick bones. So then they're easily broken. And then that's a pathological fracture. Cancer, another way that bones break. Open, you see the bone. Closed, you don't see the bone. Compound, several fractures. Commuted, you see little fragments. That would be a bad day because now they've got to go in like Humpty Dumpty and put you back together again. So look at the images of your book. And I think we've gone over the major ones to know. Fat emboli. What is a fat emboli?
A heart blockage from cholesterol?
No, it's kind of like a PE, but good try on that. It happens with long bone fractures. And so what you get on a long bone fracture, right, is that, again, the immune system's like, hey, I'm going to fix you. And everything rushes to the site to fix it. But when that bone breaks, parts of it may break off. Fat, all the tissue around it, and a little piece of fat may break off. And that emboli may then, just like a PE, like a DVT to a PE, go up to the lungs and heart. Here's the weird telltale sign that it isn't a PE, but a fat emboli. A, history of the patient. Do they have a recent fracture? Yep, they broke their femur. And then B, petechiae on the chest starts to develop. It's weird. Feelings of impending doom. Absolutely. Feelings of impending doom. You see that with PE as well. But yeah, just that petechiae on the chest, difficulty breathing. And then unfortunately, all we can do is try to treat the symptoms, find the fat emboli, but it's a lot like a PE. But that petechiae is that weird, like telltale difference. Okay. Neurovascular assessment. What does neurovascular assessment mean? What's a neurovascular assessment?
Would that be like Perla and like Glasgow and stuff like that?
Yeah. And then also checking pulses, checking temperature, checking cap refill. We're looking at our vasculature, at our periphery, making sure we've got good circulation. So knowing what's normal versus abnormal when we're talking about fractures,
Baby,
good to know. What should cap refill be?
can you get me a blanket, please?
Blanket?
Yeah.
Less than 3 seconds.
Beautiful. What's turgor?
Basically, kind of how hydrated your skin is, or like how its ability to be elastic.
Yeah, absolutely. What about how should skin feel when you touch them? Warm, right? Not hot, warm. Should be warm. We don't ever want to be hot. We don't want to be cool and clammy, and we don't want to be hot. We want to be nice and warm. All right.
Huh?
Good. Now we've
Okay.
got some diagnostic tests we've listed here. I'm going to skip those now because that's going to be a fast, like rapid. What do we do this? Like uric acid is gout. ESR, that can go with rheumatoid arthritis. What's our number one diagnostic test when we talk about fractures and musculoskeletal issues, skeletal issues?
X-ray.
What do you go get when you're in the ER? You've possibly broken your wrist.
X-ray.
X-ray, yeah. Don't overthink it. X-ray, bam. That's our number one diagnostic test for like skeletal issues and whatnot. Okay, we talked about osteoporosis. Which test here, C-reactive bone mineral density, uric acid, ESR, bone biopsy, which do you think goes with osteoporosis? Which is your diagnostic test for osteoporosis?
Bone mineral density.
You got it. Excellent. Beautiful. Okay, because we got to see how dense our bones are, right? We want to make sure we got nice, dense, healthy bones. Speaking to the ladies, you were in your 20s. I think most of you are. Start your multivitamins now. Be taking calcium, be taking vitamin D. Talk to your doctor about it. Make sure it's not contraindicated. I'm not a doctor, nor do I play one on TV. But be thinking about your bone health now, because in your 30s, it's already going to start to decrease. Okay, off my little soapbox. Carpal tunnel syndrome. How do you get it?
Like long-term, like work stuff, you know, like
Yeah, repetitive. Yeah, beautiful. Repetitive movement. Administrative assistants, get it. Constantly doing the same thing. Assembly line workers, get it. Constantly doing the same thing. What else? Okay, so my mother-in-law, started as a secretary in the 70s and had like a carpal tunnel release, and that's how you treat it. You release the tendons that are right here. It's causing numbness and tingling. From that repetitive movement, you get swelling around the tendons. It causes that, then it makes the nerves angry, so your hands go numb and, it's painful. So they can go in and do a carpal tunnel release surgery. In the 70s, she's had it, and it looks like she cut her wrist. I mean, the surgery is just so graphic. And then she had another one in like the 90s, and it's like the tiniest, lovely surgical scar. So it's funny how medicine has changed. But long story short, repetitive movements, athletes, tennis, all that fun jazz, doing the same thing, you get yourself at risk for carpal tunnel syndrome. Okay, osteoporosis, I think we talked about that. This affects primarily women. Weak, porous bones, treatment, calcium, vitamin D. We want to make sure that we educate. Don't fall. I know that sounds dumb. Like, hey, please don't fall. But what are some things that put people at risk for falling in the home?
Rugs.
Yes, rugs. What else do we need? We need good lighting, good lighting, throw rugs, cords around the living room for lamps and stuff. Make sure those are taped down or covered. Small dogs. I swear to God, small dogs try to murder more people every year than anything. They just get right underfoot, and then, the patient falls over their Yorkie, and then you have a bad day. How my mom broke her hip, she was in a rolling chair. And then slipped out of the front of it and landed right on her bottom and caused a hairline fracture of her hip. So that's how so making sure that chairs are safe in the home, that you can't slip out and fall from that. So yeah, that's a bad day. Okay, so osteoporosis, don't fall. How do we educate them to not fall, right? Because we need to give them actual tips and things that they can use. Osteoarthritis. Okay, have you gone over osteoarthritis versus rheumatoid arthritis? All right, I can guarantee you're going to see a lot of test questions on this. Why? Because so many people have this. This, like COPD, you will treat someone or you will personally experience either osteoarthritis or rheumatoid arthritis. And the big thing is to understand the difference. Which one is autoimmune?
Rheumatoid.
You got it. Beautiful. Rheumatoid arthritis is symmetrical joint inflammation, okay? So what you'll see, look at the images in your PowerPoint about hands, how the hands start to look, spindle fingers, right? Joint degeneration. Good Lord, that was a hard word to say. I get my coffee going. It is autoimmune. Your body attacks itself. Why does this happen? We don't know. Are there genetic components? Yes. Do you just get hit with the unlucky stick? Yes. And so the goal is to find diagnosis as early as possible. Much like our endocrine patients, it takes a minute to get diagnosed. So it's very, very frustrating. We can put them on autoimmune medications. I don't have your PowerPoint right in front of me. We'll go over that next time. But what we want to do is prevent the joint destruction as early as possible. We want to maintain joint function as long as possible. One of the key takeaways for rheumatoid arthritis is early morning stiffness. How long is somebody stiff in the morning when they have rheumatoid arthritis?
30 minutes.
An hour or longer, okay? And I'm pointing that out because that's key. Because when we talk about osteoarthritis, there's early morning stiffness, but less than an hour, okay? So commit that to memory that osteoarthritis, you have joint stiffness, but it's less than an hour typically. And once you get up, get moving, get your stretching going, you're good. Whereas rheumatoid arthritis lasts a little bit longer, like over an hour. Osteoarthritis. And we'll go into more detail on these next tutoring session, but I just want to get through this test blueprint so you've got a really solid base for this. Osteoarthritis is not symmetrical. So it's your, Caitlin, I'm thinking about you. It's your knee from basketball. It's your right knee from basketball and your right wrist from shooting. And every time it starts, a storm comes into Kansas, you're like, whoo, my knee's acting up. That's osteoarthritis, right? So it's asymmetrical joint pain. And here's the rub of it. The treatment is pain control, right? The misconception is that as you get older, you're going to be in pain, right? You don't have to be. But unfortunately, with conditions like osteoarthritis, it's really hard to say, oh, elderly people shouldn't be in pain, but I played sports in college and now I've got all this joint pain. We need you to keep moving. All humans, if you don't use it, you lose it. So the big treatment, star circle T for osteoarthritis, is pain medicine control so that they can keep up those activities of daily living. All right. And if you think about a time, does anybody have osteoarthritis? Does anybody have joint pain yet in life? You can think of? Okay. Just me and Jonathan. Whatever, you 20-year-olds. No, I'm just joking. But okay. So think about like an elderly patient that has knee issues, right? What are they now at risk for? They're not picking up their feet while they're walking because they're hurting. They fall, they break a hip, right? So it's this keep kind of progression of stinkiness. So what you want to do is you want to keep them out of pain, keep them up with their activities of daily living. And yes, it hurts to go walking, but you got to keep doing it because actually the more you move, the better it will get with osteoarthritis. So keep it moving, pain medicine, star circle T, and that's me beating that into you for right now. Talked about rheumatoid arthritis, autoimmune, early morning joint stiffness. There's meds for it. Look in your PowerPoint at like the different deformities that you get with these osteoarthritis versus rheumatoid arthritis. Rheumatoid arthritis, remember spindle fingers, osteoarthritis, I think it's Herbert's nodes. I could be wrong on that, but look at the nodes, okay? That's important to recognize those differences. Sprain versus strain. All right, what's a sprain?
It's with the ligament.
That's right. That's right. And then a strain is like a pulled muscle. You see a lot of muscle strains for back. And then what is our treatment for sprains and strains?
Pretty much resting in ice.
And then what's C and E?
Compression, elevation.
Mm-hmm.
Beautiful. Rice it. Rest, ice, compress, and elevate. Get it. Get them on an NSAID. Get them some Motrin, some Aleve, and then ice it. and it'll be ready in about 7 years. I feel like you sprained something and it's never going to be right again, but you know, do your best. So rice. Remember, this is a sprain or a strain. So if a test question comes in and it's like patient's been diagnosed with a lower back strain, how should you move this patient? This is not a spinal cord injury, okay? So don't add to the question. Just read what it says. If it's a sprain or a strain, we're ricing. This is not, watch for C-spine and prevent them from, don't read into the question. Okay, rice, no rice. Bucks traction, we'll go over that next time because I do want y'all to see like how you put the weights. Big thing with Bucks traction is it's hard to do. Has anybody gotten to do Bucks traction in clinical? I know there's some people on an ortho unit at KU. Okay, Bucks traction is pretty confusing, but once you do it a couple times, much like chest tubes, you'll be good with it. It's all about a weights and pulley system, and what you're doing is you're maintaining traction. What you're doing, and it's usually before they go into surgery to correct whatever the fracture is, the hip, the leg, whatever, and you're pulling the bones apart. So what it does is A, it decreases pain, B, it aligns it so that before we can get you to OR, there's no weird healing or anything like that. Those are the two big reasons we do Bucks traction. There's some more listed in your PowerPoint, so read through that. But the thing is, you've got to like maintain the weights, right? It's got to be the appropriate amount of weight for your patient. And then the weights need to be hanging off the bed. Again, this is where patients' family members can do you in because they'll come in and they'll mess with the patient. And that's okay too. They'll hug the patient, see what the patient's doing, all that fun stuff. But maybe they knock the weights and now the weights are just resting on the bed, or the weights are now somebody's jostled them and now they're just sitting on the floor. So if the weights aren't holding that tension, we're not doing any good. And when that orthopedic surgeon walks into the room and sees that his patient is not in Bucks traction, she's going to go up and turn left, or he's going to go up and turn left, and it's a bad day for everybody. So big thing with Bucks traction is what's the mechanism of action of it? And then how do we like take care of it? Okay. And we'll talk more about that as we get closer. Okay. Burns. You haven't gotten to burns yet, and you haven't really gotten to skin yet, but I'm going to go ahead and dive in just so that you're ready to go for lecture, and then I'll let y'all go for today because it's already, well, no, it's already, 8:35. Okay, burns. I love burns. There are many different types of burns, right? You can get a thermal burn, an electrical burn. You can get smoke inhalation burn. What are some other types of burns that I'm forgetting off the top of my head?
Chemical burn.
Chemical, yes, chemical burns, yeah, all that jazz. Which one do you think is the iceberg injury? Which one is the iceberg burn? Meaning you can't see what's under the surface.
Chemical.
Electrical. So what you see with electrical burns, right? Think about our linemen out there. And actually there's a story of like a baseball coach that went up and was adjusting the scoreboard and got electrocuted. What happens is electricity will come in, a point of entry. It will travel through the body. It will travel the path of least resistance, arteries, veins, tendons, and then it will exit the body. So what you see on the patient is going in the hand and coming out the butt, coming out the hip, coming out the thigh. And what you don't see underneath is the terrible, terrible damage that electricity has just done to that patient. What do you think electricity does to the heart?
Cause arrhythmias. Yeah, big time. Number one thing that you need to do as a nurse with an electrical burn is get them on a cardiac monitor when they get to you, because they are big time at risk for dysrhythmias. And not just right then and there. Of course, they are right then and there. A lot of times the heart will stop beating depending on the voltage. So CPR needs to happen right there, as long as the scene is safe. But it can happen 24 hours later too. So when they come in the patient for observation, maybe they, it's not a terrible burn. Somebody who's been struck by lightning, or lightning has struck next to them, you can have residual effects from that. So then you come into the hospital and we watch you for 24 hours to make sure you don't go into any kind of dysrhythmia. It's really crazy. I actually saw that in Virginia. Long story short, it's our iceberg injury. Depending on the strength of the electricity,
It can fracture long bones. It can fracture vertebrae. If they fell when they were electrocuted, you're worried about C-spine injuries. And then you go in and you CT them, and holy cow, they are just destroyed inside. I mean, not only are you taking care of this wound and the wound in their hip, but inside has just been obliterated by this electricity. So those are our iceberg injury burns, and those are really, really scary and hard to take care of. I always say scene safety. Know where your power boxes are in your house or your apartment, guys, because what are you going to do if you see a family member get electrocuted? You're immediately going to grab them, aren't you? And then you're going to be electrocuted. That story of the baseball coach, I didn't make that up. He was fixing it. He got electrocuted. What does his wife do? She immediately grabs him to try to save him, and she gets electrocuted, and they were both killed. So it's one of those terrible, terrible things that, like, you got to know where your, like, power boxes are to turn off the power so then you can save your loved one. Don't become part of the problem. The other thing is, where are your exits in your house? Do you know that? Do you have a fire exit strategy? I guarantee there's gonna be test questions on safety. I'm not joking. I cannot tell you, and I promise I'm not gonna get emotional in the tutoring session. I've seen 2 or 3 traumatic burns where a fire breaks out in the house and dad runs back in to save his family, but family went out the back and he didn't know that, and then dad died. I've seen that twice. One was in an apartment fire in Mississippi. He was leaving for work. Fire broke out in the apartment. He looked up, his house is on fire. He runs back in, but his wife had broken out a back window and jumped out the back. He went in, firefighters found him down with smoke inhalation, didn't make it. Another one was in a trailer park. There had been a gas leak, and the tenants had told the landlord that, hey, there's so funny smell. The landlord didn't do anything about it. Dad was out in the yard, big explosion in the house, in the kitchen. He runs in to try to save his family. Family member went out the back. And that's one of those things where, like, everyone, it was terrible. So that being said, in all seriousness, do you have a fire? Because it's not like in the movies where you have time to go grab your purse and wallet. Fires go fast. So make sure you educate that. What is the first thing you need to make sure is installed in your house and that you're going to educate families to have?
Fire
Smoke
extinguisher.
detectors.
Smoke detectors. Beautiful, beautiful. Know that we're going to ask that. That's common sense stuff. But if you're doing community health nursing, that's something to educate people on. I hate bars on windows. That stresses me out. Like, for, in some areas you've got to have bars on your windows, but that stresses me out. So make sure if you have that, patients have keys to those bars so they can hopefully unlock and get out. Okay, so have a fire exit strategy plan, smoke detectors, thermal burns. Thermal burns are any burn greater than 20% that covers the patient's body. Okay, how do we calculate total body surface area burn?
It's like the rule of 9. Like the arm is like 10% and the legs are 20 or something.
Beautiful, beautiful. The Parkland rule of 9s. When you get into burns, let's say that you decide that's your specialty. When they get to a burn center, they'll do the Lund-Brower. But for y'all, we want you to know the Parkland rule of 9s. So rule of 9s, 4.5 front of your face, 4.5 back of your head, right? So head, 9%. Front of arm, 4.5, back of arm, 4.5, 9. 18 chest, 18 back, 18 front of leg, 18 back of leg. Yeah, front of leg, back of leg. 1% genital. Patient's hand is 1%. So if you see blotchy burns on them, use the patient's hand to estimate, right? It doesn't have to be perfect, but we need to get an estimate, because then that's going to determine how much fluid we give them, because these patients are at risk for hypovolemic shock, like I said. So you're at a scene, you're driving home from clinical, you see a car roll over, the car bursts into flames, you jump out, scene is safe, you pull the patient out of the thing. How are you going to put the fire out on the patient?
With a blanket, like
roll them, blanket, just like you learned, in October Fire Safety Month in elementary school. Roll the patient, put them out. Always maintain your safety. Do not add to the problem. Do not get injured. Do not add to the problem. Now, we've got somebody, we've put the fire out. What do we want to put on them? We got to stop the burning process. So cool, wet, not cold, not ice, never ice a burn. Cool, wet if we can. Now we got to be careful because if it's a large surface area burn, there goes into like some, hypothermia stuff. But basically, we want to stop the burning process. Okay, now how many IVs do you think we're starting on this patient? Yeah, about 37 if you can get it. Definitely two large bore IVs. We're starting that. And then it's ABC, airway, breathing, circulation. Okay. A lot of times if it's a house fire, thermal and smoke inhalation go hand in hand. If you've got both, the mortality rate goes up to 70%. Okay. So you don't want a smoke inhalation burn on top of a thermal burn. But a lot of times those go hand in hand. You get him to the ER. We've got him naked. We've done our rule of nines. Now we got to calculate how much fluid to give them. Now there will be test questions where we're going to tell you where the patient's burned and you've got to calculate it. Know that we're not going to get tricky with it. At least we didn't in the past, and I can't imagine Professor Stahl getting tricky with it. But it'll be like patient presents to the ER with the entire front. All right, let's do it right now. Entire front of the right arm burned. The entire chest burned, and the entire back burned. What percent, and you'll have to write it in, what percent total body surface area burn is that?
40.5.
40.5, great. So entire chest, 18, entire back, 18, front of right arm, 4.5, 40.5. That's a bad day. Okay. So now we got to calculate it. Does anybody know the Parkland burn formula? Okay, so we've got our 40.5. So it's 4 milliliters times the patient's weight times total body surface area burned. So we got to, sometimes if we don't have the weight, we got to estimate it. But let's say our patient weighs 80 kilograms. So we got 40.5 times 4 times 80. What'd y'all get? Making sure to tell you, I'm looking it up real quick. I'm looking at my math. Okay, so you should have gotten, beautiful, 12,960 milliliters of fluid we're going to give this patient. Think about that. That's a lot. On a regular day in the hospital, maybe we're running 1,000. I don't know, like I'm not going to do an estimate like that, but that's a lot of fluid we're giving this patient. We're going to give the first half in the first 8 hours. So expect a question where you got to figure out how much fluid we're giving this patient. And then the very next question is, how much are you given in the first 8 hours? So you would take that 12,960 divide by 2, and you're giving 6,480 milliliters of fluid in the first 8 hours. Uh-oh, now I want to know how many, like what's your hourly rate? Easy peasy, take that, divide by 8, 810 milliliters an hour. I can already tell you that we would probably need more fluids on that. But 810 milliliters an hour. You're definitely going to need 2 IVs to get all that fluid, or probably a central line if you haven't already gotten one, to get all that fluid in the patient. Now, how do you know your fluid resuscitation is effective? What are you going to be assessing? What do you think?
Peripheral pulses.
Peripheral pulses. And then your vital signs, make sure those stay nice and stable. But what are you going to be looking at every hour?
Eyes and O's.
That's my, say it again.
Oh, Eyes and O's.
Beautiful. Urine output. You got to make sure they're peeing. We want at least with our burn patients, 30 to 50 milliliters per hour. We can still stick by that 0.5 to 1 milliliters per kilogram per hour. That's pretty good. There won't be any trickery like but we definitely want to make sure that our urine output is solid, because if not, then they're probably going into hypovolemic shock and we need to up the fluid. That's our telltale sign with burns. Burns is going to be urine output. Those go hand in hand. Okay, very good. So get comfortable with Parkland burn formula, how to calculate it, how much fluid you're going to get. Okay, so we've done the first 8 hours, and then you give the rest over the next 16 hours for a total of 24 hours. So then you'd give another 6,000 and something divided by 16 per hour. So it drops off. That the first 48 hours is really, really tricky with the total body surface area burn. Not only are you worried about hypovolemic shock, but you're also worried about airway and heart and all that kind of stuff, and dysrhythmias. So burns are really, really tricky. Okay, I'll stop there on burns. I know I'm going over a lot of stuff. Any questions off the top of your head? Anything you're worried about? No. Okay, good.
So,
Go ahead.
For legs, for like the rule of 9, did you say it was 18 each side or 18 as a whole?
18 front of leg, 18 back. Well, wait, hold on. Oh man, I may have just messed up. Here, let me share my thing. It's the whole leg. I knew it. Let me share my screen so you can see exactly what I'm talking about. Stop share. Thank you for saying that. Okay, so check out this little guy right here, a little fat guy. So I gotta move y'all. How do I move y'all? Come here, y'all. Can y'all see the Parkland burn formula example? Okay, great. So entire right leg is 18. I apologize. So the front of the right leg is 9, the back of the right leg is 9, and then they're right over there. So 18 total for the leg. The entire right arm is 9, entire left arm is 9, front is 4.5, back is 4.5. Groin is 1%, entire head is 9%, face is 4.5, back of the head is 4.5. Thank you. I apologize for getting that confusing. All right. What other questions? Okay, so I am tracking that we are going to meet. There's another tutoring session on Sunday night, I think it is. Let me look at my little nifty difty. Yes, I've got a Sunday night one, and then we've got one on Tuesday night, and then your test is on Thursday. So my plan for next week, go over all the skin stuff. You're going to itch. You're going to itch so bad. Oh God, when we start talking about bed bugs and like scabies and lice. Yeah. So we'll talk about all that fun jazz. By the way, can lice jump? No, it's a big common misconception. Is lice socioeconomic status dependent? Do more poor people get lice than rich people? No. I worked at a camp in upstate New York. It was all the rich kids from Manhattan and New Jersey, and like 2 girls had lice, beautiful. And of course, it's the girls with the biggest, thickest hair. Parents were already on their private jet to Martha's Vineyard for the summer. It was the craziest thing I've ever seen. But mom calls, literally did not know this was a job, a nitpicker. The lady flies into the camp and sat and picked out, even though we were also doing it, but sat and picked out every single little lice egg and nit is what they're called. I didn't know that was a job that you could have. Long story short, I bring that up to point out it is not socioeconomic status dependent. Poor, rich, does not matter. You can get lice. You see it when you share brushes, share towels, share hair ties. Elementary school, oh Lord, these little girls go in and hug you, and boys too. Everyone's hugging each other. You're gonna get lice. So don't let kids touch you. Way on that. All right, I joke. But okay, so lice and then scabies. We'll talk about that. We're going to talk about psoriasis and then skin cancer. Real quick, what's our ABCDE of skin cancer? Do we know?
Asymmetry, border, color, diameter.
Beautiful.
And
Is it like evolving?
Elevation.
oh yeah.
Beautiful. Evolving. It's changing in appearance. What was brown is now black. Yeah, what was brown is now white. That kind of stuff. Absolutely. There's your AB. Who's most at risk for skin cancer?
Pale people.
Mm-hmm. You blonde hair, blue eyed people, you're more at risk for skin cancer. Okay, here is a common misconception and one that we need to make sure that we're not having health disparities in healthcare. Do African Americans or people of color need to wear sunblock?
Yes.
Yes. You will be shocked at how many patients do not think that they need to wear sunblock because they've got more melanin in their skin. Absolutely not. Everyone needs to wear sunblock. Okay. Cool. I'm trying to think of anything else off the top of my head. No. Did anybody see the eclipse? Did y'all go see the eclipse? Did it come through Kansas? So jealous. All right. Cool. Do not hesitate to reach out with any questions. Otherwise, I will hopefully see y'all Sunday night. I did tell a student I'm not recording these, but if you can't come to Sunday night or Tuesday night, and you're really worried about this, please reach out to me. I'm happy to try to meet with you one-on-one if we need to, okay? All right, team, go have a great week. Thank you.
Thank you.
Bye, guys.
Thank you.